of the Board of Directors. And a special welcome to our guest speaker, Dr. Ola Landgren, and our guest from Sylvester. I would like to say a special thank you to all of you and to all of our chapters who, despite the difficulties of this past year, have done an amazing job in fundraising. We are one PAP Corps, and it was proven this year with how committed and passionate our members were. So many thanks to all of you. So we have a fairly full program, so let's get started. I would like to introduce Dr. Doreen Heisler, Officer at Large of the Board of Directors, who will introduce our guest speaker.
Good morning to you all. Before I introduce the doctor, I would like to remind you that there will be a question and answer session after the doctor speaks. If you have a question, you can submit it through chat, or if you have a Q&A button, you can do it that way. Dr. Landgren is chief of the myeloma program and leader of the experimental therapeutics program at Sylvester Comprehensive Cancer Center at the University of Miami. Previously, he served as the chief of the myeloma program at Memorial Sloan Kettering Cancer Center in New York. Over the past several years, he has designed and conducted a series of studies to define biological mechanisms of transformation from myeloma precursor disease to multiple myeloma. His work has resulted in the identification of myeloma genomic defining events, which sets the stage for optimized treatment, initiation of patients with early myeloma, and identification of individuals who can be monitored without therapy. Dr. Landgren has launched several early interventional clinical trials designed to offer rapid and deep responses. Beyond traditional clinical criteria for complete remission, he has developed strategies to define minimal residual disease, MRD, detection post-therapy using cell molecular and imaging-based methods. Dr. Landgren has a strong interest in early drug development, and he has served as the principal investigator for a large number of clinical trials with novel drugs and with integration of MRD testing. He is a frequently invited speaker at national and international meetings. He serves on several advisory boards, and he is a frequent grant reviewer. He has published more than 400 peer-reviewed publications, including many papers in high-impact journals such as New England Journal of Medicine, The Lancet, JAMA, Blood, and Journal of Clinical Oncology. And I'm proud to present Dr. Ola Landgren.
Thank you very much for those kind words, and thank you very much for having me. First of all, I would like to thank the PAP Corps so much for all your support on the Cancer Center. I joined here a little bit less than half a year ago, and I'm really very excited. I came here and I see this as a fantastic opportunity to help and continue to build and develop under the leadership of Dr. Stephen Neimer, whom I've known for a long time. Stephen worked at Sloan Kettering, where I came from before I came here to Florida. I put together a couple of slides, and because of this terrible year with COVID, we cannot really meet and see each other. I thought, how do I share a little bit about myself before I dive into some of the weeds of what I'm doing professionally? So I decided to put a few slides. Can you see my slides here? About myself. I just have a few slides to give you a brief background of me. So this is my family. I am very happy to have two beautiful daughters, a beautiful wife, and a young, beautiful son. So on the left, Linnea, then we have Elizabeth, my wife Heather, and Magnus on the right. Magnus is only 3.5 years old. We all have lots of fun. We love being in Florida. I was born and raised in the south of Sweden. My family comes from there. My dad's family, actually my grandfather tracked back to mid-1600s from Lund, which is an old university town. My high school is on the right there. It's actually founded all the way back in 1085. I moved to Stockholm, where I did med school at the Karolinska Institute, which is also the home institution, as you may know, for the Nobel Prize. So I was very fortunate to be there, and it was really an awesome time. In 2004, I was recruited to the National Institute of Health and the National Cancer Institute. And I was initially coming to spend maybe 2 or so years, but I ended up being recruited after about 3 years, and I was on faculty and I became tenured. And then I thought I'd probably stay there forever. But I stayed for about 10 years, and then I was recruited to come to Sloan Kettering in New York. And that was a fantastic opportunity. So I thought maybe I stay here forever. But then Steve Neimer said, you know, there is a life after New York. Why don't you come to Miami? So after 7 years of Sloan Kettering, I came here to Miami, and I'm really very happy here. And I feel we have so many opportunities to do many important and fun things together. So I've set up the myeloma program here the past few months together with a team. And I think I hired between 10 and 15 people already. I've only been here for 5 months. The goal of the program is to make sure that we stay very clinically focused on our deliverables. We will continue to deliver the best possible therapy and monitoring and care for all our patients. We will offer this across both the site in main campus, downtown Miami, as well as all the other sites that we're setting up around the city. It's important to provide patients with access to the care that we develop internally. From a strategic and development point of view, we will continue to focus on novel treatment strategies, and we will be relentlessly looking to find a cure for multiple myeloma. And if you don't know about myeloma, I can tell you it's the second most common hematologic malignancy. It affects about 35,000 people every year in the US. We do not have a cure yet for myeloma, so patients unfortunately will be on therapy from diagnosis going forward. There are about 150,000 people living with myeloma. We have set up a program. I work on this every day, trying to put the team together with all the doctors, navigators, nurses, research people in a very integrated manner. And I start off showing this before I dive into the details of the research we do, because I truly think working as a team, as a family, that's how you can deliver and make sure you stay focused on the patients in the end. So all the research we do comes back and we deliver it in the clinic. I'm very much a family-oriented person. I come from a big family in Europe myself. The family is very important to me. So I think of this as one big family. The needs for the disease go all the way from the precursor to patients who are newly diagnosed, and if the disease comes back, patients relapsing, or they could develop refractory disease. Patients who are having the precursor disease typically don't know they have it. It could be found in the blood with a blood test. Patients who are newly diagnosed many times are symptomatic, but not always. And patients with relapse refractory disease obviously could suffer from a lot of symptoms. We focus on biomarker discovery. We are focusing on early intervention, early treatment strategies. For patients who have the disease, we are developing newer concepts I will share with you here in a few seconds. We are focusing on something called minimal residual disease negativity. We are actually quite successful in getting rid of most of the disease in a very high proportion of patients. And I will share with you in a little bit. And for relapse refractory, trying to develop new drugs. So questions we are looking at are early intervention, why not, type of therapy, risk of progression, different strategies. I mentioned different combinations of drugs, when to start the therapy, and for the relapse, what type of strategies for early or later relapses, focusing on detection of low levels of disease, symptomatic disease. We're building the program on investigator-initiated studies. So some centers internationally and here in the US, they work directly with drug companies. They open the drug company studies on their behalf because the drug companies want to do drug development and get the drugs approved. But the investigator-initiated studies are ideas that people at the institution develop, ask the drug company if they can provide them drugs for free to really try to push the envelope and do new scientific discoveries with drugs that could be given in new settings. So that's what these investigator-initiated studies are about. And I worked on that for many years. We need external grant funding to do this, and we work with different institutions, from donors, foundations, and ask for that. And we also apply, of course, for federal grants to the NIH. And we have been quite successful, but we, of course, always look for additional support. Also, the companies come to us when they have new compounds to see if these new drugs could be developed in settings where there is nothing that currently works. And we are interested in working with the absolutely newest, what's called first-in-man compounds. And we have a lot of experience with that as well. When I came here to Miami, there were two doctors, Dr. Hoffman and Alves. And I came here in the end of last year, and I mentioned I hired several people. So these two doctors, Dr. Mora and Sanjan, I have hired, and I have two more names that have not officially been disclosed, so I didn't put them on the slide, but there are two more doctors that will join here just in a few months. So we are growing very fast. Here's an example of a study that we will publish just in the coming 2 weeks, coming out in one of the JAMA journals. We show that when we combine the newest drugs we have developed, these have a lot of acronym names, called KOD, daratumumab, is a proteasome inhibitor, an immunomodulatory drug with an immunotherapy. We actually can unbelievably show that 71% of patients have no detectable disease after we have given them 8 cycles of therapy. And when I started treating patients more than 20, 25 years ago, unfortunately, the average patient lived for only 1 to 3 years. So here we are seeing that after 8 cycles of therapy, 71% have no detectable disease. This is the best we have ever seen. And we just are about to open a new study called the ADVANCE study that randomizes this new therapy that you're looking at here compared to current standard of care. There are already about 10 centers across the country that will participate in this study. And we're hoping that this could become approved by the FDA and become a new paradigm for treating newly diagnosed patients. This is what we see even without the bone marrow transplantation. So these results are in the absence of that. In the past, we always transplanted every patient. So we are changing that too. I mentioned that myeloma could have a precursor. There are a lot of details. I'll try to be brief and to the point here. What we have shown in patients with myeloma is that there are a lot of genomic changes. You can see thousands of mutations in the cells. If you look from the left to the right for myeloma, every color represents a subclone of the disease evolving. And when you see that it goes down to a very thin line, that represents when the therapy is given. Because we unfortunately don't have an established cure, patient will then have a relapse, and that's where the next kind of circle pops out in the end of that myeloma. So one idea has been, if you go a little bit earlier, if you treat patients that don't necessarily fulfill the criteria, if you go after something called high-risk smoldering myeloma, could you achieve better outcome? Could you cure these patients? So the data suggests that, unfortunately, there are less clones, but the disease will still come back. So that takes us to the next question. What about if we go really early? Could we go into the so-called monoclonal gammopathy, where patients have very few of these cells? And could we identify people who are genomically programmed to develop the cancer? So if we couldn't do that, if we just treat all these individuals, we would probably overtreat very many patients, and that would not be ethically justifiable. So to test this hypothesis, that would imply that you have to do a lot of complicated testing. For example, whole genome sequencing could be applied. So in red, these are people who don't progress, and in blue are people who unfortunately do progress. So could we sort out in these very early stages of disease who is going to progress and not? That could really change the field. So this sounds like a very simple question, but the problem is that if you apply whole genome sequencing, you need, unfortunately, a few 100,000 cells in order to test the DNA and see if you have these different genomic alterations. And in a person who has hundreds of thousands of these abnormal cells, that person already is filled with a lot of disease. So probably these tests are not really that useful. So the question is more applicable to someone who has very few cells. So we were able to work together with the Sanger Wellcome Institute in the UK and develop a low DNA input strategy. With only a few thousand cells, we have been able to do whole genome sequencing. And this was published just 2 weeks ago in Nature Communications. Taking this approach, we were able to show that there are activation of pathways and signatures that we have never been able to address before. There's a lot of detail. So if you pay attention to the right, on the very right, it says RRMM. These are samples from patients with relapse and refractory myeloma. If you look at the red box, these are newly diagnosed patients. And then you look at the purple box. These are patients who have this monoclonal gammopathy, very limited number of cells in their bone marrow, and they are not sick. But these are people where we follow them for a few years and they progressed. And then if you look to the very left, there is a black simple line sitting at 0.00. These are also samples from people with this monoclonal gammopathy, but they did not progress during the same time window. And you now see in this dotted area that there is a big difference between the ones who did progress versus those who didn't progress. And you see that the purple are very similar to the red and the maroon. So basically what I'm showing you is that you can genomically identify people who are pre-programmed into cancer. And of course, this is a huge observation, and we are now working very fast to move forward with this to try to replicate and expand this into larger sample size. We also looked into additional other changes. There's something called templated insertions, something called single variance hotspots, and there was something called genomic catastrophic events called chromotripsis. And you can also see that there are striking differences between people who progress versus don't progress. So I think we now have a genomic signature of people that are programmed almost like myeloma to be. And what we are planning on doing now is to open a large study here. I would like to open a study in Miami in this fall, where I would like to invite up to 1,000 people who want to come here and do a biopsy if they have these low levels of disease. Currently, they're followed with blood tests on a regular basis, anything from a few months up to annually, and they don't know if they're going to develop cancer or not. I would like to change that. So I would like to do a study where we have 1,000 people that can come here, we can do a biopsy, we can apply all these technologies. And in my lab, we know exactly how to analyze all the data to see if people have or don't have. And I'm also working with some of the biotech companies that have the newest immunotherapies to see how we could offer people who have these early changes at their own discretion, at their own decision, if they want to enroll in an early intervention study to see if we could actually get rid of these cells. So the goal here is to see if we could identify the disease early and see if we could seek some form of a curative approach. So I think we have this finding. There's urgent need to expand it and to put it into context of other factors. So is this the right time to start therapy? I think the answer to these questions in Orange is yes, yes. I want to share with you a couple of more things before I end here. I think identifying disease early, hit the disease with the right drugs is important. But also, like anything else in life, you have to check and make sure you did the right thing. So tracking of residual disease and ruling out residual disease, I think is very, very important. And I've spent a lot of time working on this. For more than 10 years, I worked on different strategies trying to find the last cells. What you're looking at here is an antibody that binds to something called CD38 that's expressed on the surface of myeloma cells. And we have linked this to something called a DFA chelator. And then we have labeled this with something called zirconium 89. So this allows us to inject very small amounts of antibody, and then we can have the individual. We started off in mice, we put the mice in a camera, and we could use a PET scanner and see if we could find these antibodies. What you're looking at here on the left or on the top, mice where we first injected cell lines. On the lower left, mice without cell lines. And if you move to the very right on the top versus the bottom, you can see that these antibodies are detectable in the areas on the top, but not in the bottom because there are no myeloma cell lines. And they're labeled with zirconium 89. We did this and we're able to prove that this actually works. We then took the data, we put it in a protocol, we wrote it, and we sent it to the FDA and asked for permission to try this in humans. And we enrolled 10 patients to try to figure out how to do this right with a lot of detail. And we published this about 12 months ago. This led us also to think about how we could use this as an extension of a new study. So this is from the phase 1 study. We show that the antibody penetrates human tissue in about 5 days. And we also show that the half-life of this zirconium-89 is long enough to allow us to detect disease. It actually has more than 7 days of half-life. So this is really an ultimate combination. Here you see on the lower right, the very right, a black dot. These are antibodies. In the middle, you see CT. And so there are holes in the bone. On the left, there's the fusion of the image with the antibody and the CT. Here's an example of a patient's leg, whether maybe it's myeloma or not. This is what the radiologist is currently looking at. And when we injected this with antibody, you see that there is a lot of disease. Here we have FDG PET-CT, the standard of care PET-CT. That's used in every hospital around the world. This is the standard. When a patient does a PET-CT, this is what it is. It's actually glucose that's labeled and allows tracking. This patient did the antibody within a week after, and this is the same patient 1 week later with this zirconium-89 antibody. And you can see with your own eyes that there are multiple areas where this lights up. So actually, later today at 12 o'clock Eastern time, we are having our site initiating visit for a startup for the phase 2 study. And we will now image another 60 patients with this new antibody. And we were trying to expand this work. And the idea is also, if we find any of these residual sites, if patients agree to do an image-guided biopsy, so patient can be in the camera, we can have a very thin needle and take out these cells. And then we're going to apply the same technology I showed you with the low DNA input technology to try to characterize these cells. So the idea is, if you have a person who's treated, who's basically clean, except there are a few sites, what do those sites have in common? Do they have the same genomic signature? And also across patients, is it the same? Could we find the Achilles heel and try to cure the disease? The last slides I show before I wrap up here comes from a study where we looked at how the disease comes back genomically if there is a relapse. It's hard to study this. We set up a study at Sloan Kettering when I was there. Patients who sadly passed away from myeloma could participate in a protocol called the Last Wish protocol. In the unfortunate event of passing away, patient could consent to participate in a warm autopsy, allowing full characterization of the disease. Patients were tested in multiple sites, and this allowed us to show that unbelievably over 10,000 mutations could be identified by whole genome sequencing. We could use this to do what's called reconstruction of the phylogenetic tree of the disease. So think of it as a trunk of a tree with branches, and there are branches of the branch, and there are branches of the branches of the branch, and so forth. And we could really study how the disease has evolved in the body. And we could go all the way back to where the disease started, taking very advanced bioinformatic approaches that we have in my laboratory. We also use, in this type of analysis, mutational acquisitions as a measure of time. You can actually take a sample in a human and you take another sample in the same human at another time point, and you can estimate the time difference between these two time points. Because as life goes on, we will acquire more and more mutations. So it's possible to use this as a genomic clock. So what we did was we looked at the genomic clock and we looked at the phylogenetic tree, and then we were able to study what's the time window of the relapse? What's the time window of the initiation of the disease? What we unbelievably have found here, which is something I would never have guessed, is that the average age of diagnosis with myeloma is around 70, but we show that the first cells start around age 20 to 30. They sit dormant for between 40 and 50 years. Patient can be treated and have a good response and be MRD negative, but what is responsible for at least the later recurrences is a single cell. There's one cell that goes crazy, and that goes very, very fast, accelerated in a seeding manner within months. And that is what the relapse is. So this really pushes me even more in my group to try to find that last cell, those last cells. It may be few cells. That's why we need to drill deeper into this MRD business and try to find these cells and try to get rid of them. Then we could go maybe for a cure. I would like to thank all my collaborators. This is my team, our external collaborators in different places around the world. I'd like to thank my clinical colleagues and our funding support. And I'd like to thank you so much for your attention. Thank you.
Okay. Okay, well, thank you, Dr. Landgren. We have some questions. Okay, the first question, what distinguishes one myeloma from any other MPN blood disease?
What distinguishes multiple myeloma from other MPN blood diseases? Well, so multiple myeloma is a disease that is known to originate from plasma cells in the bone marrow. MPN, presumably in this context, stands for myeloproliferative malignancies. So that would refer to something called the myeloid cells. The myeloid cells and the plasma cells are all part of the immune system. The immune system is a range of different types of cells. And I think you could simplify the immune system by saying that there is the cellular side, but the myeloid cells are part of that. And then there is the humoral side, where the plasma cells are a key component. And the humoral side, that's the plasma cells, they make antibodies. So the antibodies are made by the plasma cells and they go out and attack things like infections and things. The cellular side of the immune system, those cells go right after the target. So myeloma is a cancer of the plasma cells. The MPN diseases are cancers of different kinds of the parts of the cellular system. So that would be my answer back. Different types of diseases, but they have a lot of things in common, but they're also very different.
Okay, thank you. I have another question. What are the early symptoms of myeloma? Is there a genetic component that has been defined?
Those are great questions. So the early signs of myeloma can be very, very diffuse. And unfortunately, they are not unique to this disease. There are things that a lot of people would say, oh, I have that too. So for example, people could feel tired, fatigued. Most people doing COVID say, oh, I feel the same. Well, I feel the same too. Doing COVID is not so fun. But also people could say I have back pain. Well, a lot of people say I have back pain too, but that doesn't mean that people have myeloma. But things like that could be part of myeloma. So it could be very diffuse. It could be like bruising, recurrent infections, or things like that. So very diffuse. But as the disease gets more and more advanced, unfortunately, it could lead to very strong pain. That could take a person to the doctor. Rare cases could unfortunately have high levels of these proteins that the disease makes sent out in the blood that could end up in the urine. That could cause advanced impact on the kidney, could lead to acute kidney insufficiency, could take the person to the emergency room. And the doctors don't know in the emergency room what's going on. And workup after a few days shows, oh, the patient actually has myeloma. That's why he or she is so sick and has kidney failure. People could come even into dialysis. That's rare, but could happen. And if you treat fast and do it right, everything could reverse and the person could go back to normal life again. Unfortunately, there are some people who have something called pathological fractures. So I've done it for 20, 25 years. So I've seen very many different things. So I saw one patient, he was out at the airport at Los Angeles, at LAX, and took his bag and put it on the conveyor belt and flew back to the East Coast. And when he took the bag, it hurt a lot in the arm. He got on the plane, and when he landed on the East Coast, he had so much pain, so he went to the emergency room. And when they worked him up, he actually had a fracture in his upper left arm. That turned out to be myeloma. He didn't know he had myeloma at the time. So pathological fractures could even present as myeloma. When I look through charts for patients who have myeloma, many times when I know the answer, I can see that the person has had symptoms many times for almost a year. It's very common if you ask the patient to say, when did this really start? It probably was last summer, or you start looking at the labs. But I would say no one did anything wrong. It's just that it's so difficult. But I do think these genomic tests we are developing could really be game changers, because they show very distinct signatures that has never been found before. So I'm very hopeful about that.
Okay, thank you. I have two more questions. You stated that 71% of patients showed improvement after 8 cycles of therapy.
Right.
Are 8 cycles, the question just moved, are 8 cycles the limit?
Say that again, please.
Okay. I'm asking about the cycles. You mentioned the 8 cycles. Okay, and
Yep.
71% of your patients showed improvement. So are 8 cycles, the question is, are 8 cycles the limit?
Okay, so another great question. So I should actually restate my claim there. I tried to make it simplified, but really what it is this. So we treated on this very study 41 individuals, and they all had multiple myeloma. And we said, what is the best response within 8 cycles? That's how the study was designed for various reasons. What we show is that with this new therapy, some patients have no detectable disease, even with the most sensitive technology we have. We have technologies that can find one tumor cell in 1 million investigated cells, and we can go through millions and millions of cells. We actually found that patients with this new therapy were cleared from disease within 1 month. Unbelievable. I've never seen it in my whole life. There were patients who had it after 2 months and 3 and 4 months. The average time was about 5 to 6 months. And when we said how many people in this cohort of individuals have no detectable cells with this very sensitive assay as a best response within 8 cycles, that's where 71% is true. So really, the correct way of saying is that however fast it happened, at least within 8 cycles, how many did not have any evidence of detectable disease? That is 71%, which is unremarkable. It's fantastic. But if you ask the other question and say, could you give 9 or 10 cycles? You probably can. You can probably give 12 cycles, but also is a lot of work for a patient to come in. And if you have no detectable disease, how long do you have to treat with this intense therapy? So I think what we are doing is we give these injections and infusions, and then after a certain number of cycles, in this case 8 cycles, we turn to what's called maintenance, which is usually tablets. Patients do blood tests 4 times a year, so every 3 months, and then they take tablets on their own, and they live, I would say, pretty normal lives. And I have patients, I have a manuscript hopefully will publish very soon in one of the Lancet journals. We are about to finish the last revisions. We see that there are patients on these tablets for over 10 years. So the next question is, can you go off the therapy? And I think probably some patient can, but it's a little bit too early to say who they are, because there probably are biomarkers we have to use in order to guide, so we don't take people off and the disease comes back in every patient. That's something we don't want. But I think that's where the field is heading. And I actually strongly believe if we can detect the disease earlier, we can deliver these modern therapies that can minimize the long-term toxicity, and we can track and make sure there is no detectable disease. If we can do that for a window of time, if there repeatedly is no evidence of residual disease, I think we actually can deliver a cure. I do honestly think so.
Okay. And this is our last question. Is stem cell transplant a treatment?
Stem cell transplant is one of the treatments for this disease, similar to many other diseases. So importantly, when we use the word transplant, we think that it's a matter of giving something that would be the vehicle as the treatment. But importantly, in this disease, there is something called allogeneic transplant, where you have a donor giving his or her bone marrow to a recipient. That is infrequently used, and it doesn't really work in this disease, and it's also very toxic and causes a lot of problems, can be lethal, unfortunately, for many patients with myeloma. Then there is something called autologous transplant, which is not really an accurate terminology, but that is commonly used. That is actually the delivery of high doses of chemotherapy, of melphalan chemotherapy, that is very toxic. So if you give that to a person, he or she could actually, unfortunately, pass away from the chemotherapy. So in order to justify that, it was found in the 1980s that if you take out some of the stem cells and then you give the chemotherapy to the person, and then you, after that, give back some of the stem cells, you take them temporarily out of the body, you rescue them, then these stem cells would regain the immune system. They are not treating the disease, but they are helping the body to recover from the chemotherapy. So it's really just a high dose of chemotherapy. That is, in layman's term, referred to as transplant, but it's really chemotherapy. That is still something that's used many places, both here in the US and internationally. But if I look at where the field is going, there was a presentation about 6 months ago from a large French study. They show there is no survival benefit with this procedure. It was very popular years ago because there were no other treatment options. But I think all the new drugs look so much better. So I think this is something that will go away, and I hope it will.
Okay, well, Dr. Landgren, thank you for you and your team for the depth of your research and, of course, for helping humanity. And have a good day.
Thank you so much for having me. Thank you very, very much. Thank you. Thank you for all your support to the center.
Okay, thank you. Okay, now I'd like to introduce Sally Berenswag, our CEO.
Thank you, Doreen. I'm so happy to have you all here with us. By now, you've all received the PAPCOR Press via email. You will be getting it printed. And I thank so many of you for reaching out and telling me how much you loved it. I loved making it. If you, our next PAPCOR Press will come out at the end of June. And so I really encourage you to send me pictures of things happening in your chapter or any ideas that you would like included in the PAPCOR Press. Again, it's for you, and I want you to enjoy it. The other thing is that you'll notice that there were advertisements in the PAPCOR Press. And we did this so we could actually pay to have them printed. And I'm happy to say we were able to pay for them to be printed for all of you for this, this issue. So now coming to the June issue, if any of you would like to place an ad or a sponsorship for the PAPCOR Press, please reach out to me. You will get credit and your chapter will get credit if you're able to provide an ad or sponsorship for the PAPCOR Press. The whole goal is really to be able to print this for you. And of course, the printing costs a lot of money, so we need to put the ads in and have the sponsorship. The same will be for the president's meetings. We are going to be looking for sponsors to help us when we are able, we're hopeful in October to resume our in-person president's meetings. I also wanted to share about 2 other new programs. One that we're starting and will be launched May 1st, and that's the Social Media Ambassador Program. This is a program that we're piloting here to get high school students, college students, young professionals, young mommies and up to just be pushing out everything that the PAPCOR puts out through social media. I'm really thankful, Eileen Rallo, I just want to say she actually got 5 of her grandchildren are going to be social media ambassadors. So if you have any family members, children, grandchildren, or if you would like to be a social media ambassador, please reach out to me and I can share with you what that entails. The second program that we're starting is an intern program over the summer. We are working with FAU and we're looking because we need some help in the office. So if you have any children, grandchildren, you yourself would like to come in and help, please reach out to me as well. And I thank you so much for everything that you do for the PAP Corps. And I am going to turn it over to David Becky, the treasurer of the PAP Corps. Thank you.
Good morning, everybody. First of all, I'd like to express my appreciation to all of you. As many of you know, my mom recently passed away. The outpouring of support from so many people has been so wonderful. It's another reason that I find such great value and benefit of being involved with PAP Corps. Being able to surround yourselves with such caring people is very rewarding. And once again, thank you. Today, I have some important operational news to update you on. As discussed, PAP has made the decision to change lockbox and bank providers. We've already started to receive checks into the new lockbox with PNC. In the next couple of weeks, treasurers will receive new envelopes to use that will send all checks and check summary forms to the new lockbox provider. Any items still in transit to our prior provider are already being forwarded to PNC. We all realized that our existing provider was getting slower and slower with the processing. PNC Bank services their own lockbox and will be picking up deposits from the lockbox twice per day. Plus, since they service their own lockbox, issues will be more quickly resolved. Multiple PNC associates review transactions each day. Thankfully, from a chapter perspective, with the exception of new envelopes, little, if anything, will change, except that your money will be deposited much more quickly, and that's what we've been striving for. The next topic is that you've heard for the past few months relates to our audit. We're within 2 months of being completed. We're very happy about how that will allow us to pursue corporate donors and help to improve upon our already strong rating with GuideStar, who evaluates not-for-profits. Future audit years will be quite quick as processes will be standardized and the audit model will be easy to repeat. We're all excited about the upcoming delivery of our check till Sylvester. One factor in our final gift amount relates to future expenses. One way that chapters can help the entire organization is with its projected expenses for events for the remainder of 21 and into 22. With some events, as we know, there are significant deposits in advance. Stacey's team will be sending out a form that will allow you to enter some of the expected expenses you'll have. Certainly you won't know all of that immediately, but we want to make sure that those funds are allocated in advance. We've done that over the past couple of years and it's helped significantly with cash flow. We appreciate your quick response so that we can help finalize our annual budget and provide as much to Sylvester as we possibly can. We're all looking forward to ramping up our events as vaccines are distributed. So please send in your projected events expenses so that we can accurately determine what the rest of the year looks like and we can give most generously to Sylvester. It's great that we can see a light nearing the hopeful end of the COVID tunnel. And we're as excited about the ability to get together and back into active fundraising fund. We look forward to releasing our gift amount to Sylvester next month. With that, if I may turn it back to Susan. Thank you all.
Thank you, David. I appreciate your report. So we're going to now hear from Beverly Berkowitz, our officer at large and head of the development committee. So Beverly, we're looking forward to your report.
Thanks, Susan. And I want to add my thank you to all of the presidents, members, and of course, the members of the task force, our board of directors, for coming through this year with energies and with dedication to the PAP Corps for fundraising. We all know the importance of it, and thank you all. You are all wonderful in your efforts, and it's really appreciated, as you know, by every single doctor, researcher at Sylvester. I want to start off by again talking about the giving train. We are requesting that you ask your members to consider the giving train. And we want to explain again that it is completely reliable to give dollars to the giving train. We are reliable in securing the privacy of all of your information. Those of us who are participating are sent a text message prior to the donation. This comes every single month. So we know when a donation is being made and when money is being withdrawn from whatever resource we have dedicated. I personally have been a part of this from the beginning, as I know many others have, and we all report it's seamless and safe. Most important, please share this with your members and share the benefits of this program. The first benefit, your chapter will reach new levels of revenue without cost. Each member can contribute a small amount and become part of the big picture in support of research. All contributions go directly to research at Sylvester, and this is the future. Please, it's not a burden if you consider $10 or more. Please consider telling your members all of what I've just reported and encourage them. And we do expect the giving train to stop at your chapter soon, and we will work with you if you need any assistance. Please reach out to us if you need information, and let's send the message to the next survivor that every month the PAP Corps is dedicated to them without the need of an event or any other program. It's simple, and it's a really way that your dollars will count. Okay, we're going back to the future. Footloose and cancer-free. The date, Sunday, October 3rd, 2021, at the amazing new Opal Grand Hotel in Delray Beach. We are excited to finally be going forward with this event. And we have an incredible committee working to make this year's event a wonderful experience in a safe and secure environment. I'd like to announce my co-chair for Footloose 2021, Nancy Levinson, and committee members, our presenting sponsor, Sharon Goodhart, Kay Renz, our dance coordinator and public relations, taking care of public relations, our committee members, Susan Dinter, our chair, Linda Moses, Paula Karp, Ricky Bell, Susan Greenberg, Paula Pediatric, and our CEO, Sally Berenswag. We are calling upon you to encourage couples to dance. This event truly puts the fun in fundraising. Not only is it exciting and a unique event, it is also a personal outreach by our dance couples to ask support for our mission from their neighbors and friends and other members in their chapter. If you'd like your questions answered regarding purchase of tickets or recommending a dancer, you can reach Kay at danceforpapcorps@gmail.com, or you can reach out to Beverly or Nancy at thepapcorps.org. To answer the question, if you have already paid for tickets or reserved your table prior, yes, that will be honored. Your table is waiting. So please encourage more people to join and become a part of this. I want to assure you that the hotel is COVID friendly. We're going to give a lot of details about the luncheon, the security of each one of you for safety, physical safety. And our dance couples will be informed about the requirements for dancing. A dance couple could be 2 men, 2 women, a man and a woman, 2 friends, as long as they are not children and they are not professionals. So please, it's our signature event for 2021, and we are delighted to be able to move forward and present this fundraiser to you. Again, if you have any questions, please reach out to us. Okay, I am very proud to announce this report, and it's a tribute to all of your efforts, individual donors and chapter events. And it is the best report that I'm giving today. This will underscore the generosity and commitment by all of you. The Dr. Kevin Berkowitz Memorial End of Year Campaign 2020. Last year's campaign, 2020, targeted clinical trials conducted at Sylvester trials for brain, breast, and genitourinary cancers. We were promised matching funds for breast cancer of $50,000. And I am proud to announce the income from your donations to end of year campaign totaled $307,637. And again, please accept our sincere thank you and realize that you have made a difference. We will be announcing our end of year 2021 campaign very shortly, and stay tuned for some very exciting news. Okay. The Garden of Hope. We are delighted to announce that garden construction will begin this month. Our phase 1 of the garden is beginning. Again, we thank our brick, bench, and plaque purchasers for their support and patience. Our garden projects have just begun. We are looking forward to phase 1, first planting, phase 1, second planting, phase 2, the Lake of Hope, and phase 3, the Path of Hope. This project will continue to be a major resource of fundraising dollars and a tribute to all of the PAP Corps, past, present, and future. Please continue your brick purchases, bench, and plaque purchases. Upon construction completion of the first planting, we will be announcing our grand opening of the garden event, and we look forward to that late summer, early fall. We are looking forward to enjoy together this beautiful place of tranquility. And we are all committed to the next survivor, and that one day a cure for all types of cancer will happen. A world free of cancer, with a garden representing the PAP Corps' journey to get there. Thank you. I also would like to give you a report from Sarah Landgren, who is not able to be here today. Sarah has hosted wonderful events, and again, an event is happening this month in Palm Beach County, the 2021 Wine Dinner. It is Wednesday, April 21st at the Stage in Palm Beach Gardens. It's a wonderful VIP champagne pairing. I believe it's a 5-course dinner, and we are looking forward to wonderful news, the outcome of this for people who are attending. And of course, Sarah has done a wonderful job. It's being hosted by the Stage, Todd Whitman, and Penfolds is sponsoring it. So again, I want to shout out and say thank you to all of you. This past year has been difficult for every single one of us, but as always, the PAP Corps shines through. Thank you and stay well.
Thank you, Beverly, for that great report. Okay, we've come to the end of our meeting today. I thought Dr. Landgren was wonderful. I think that we at the PAP Corps are very, very lucky that we have the opportunity to have top-notch doctors from Sylvester come and speak to us. So anyway, I always appreciate all of them, as I'm sure all of you do. One announcement before we end: the Policy and Procedures Manual is in its final review, and so we'll go to print shortly. We will notify the presidents once it is ready, and we will arrange times to pick up not only the Policy and Procedures Manual, but the PAP Corps Press, the new lockbox envelopes, and some marketing flyers. And we'll have more than one time that the presidents come. We'll try to, I think Stacia, if I'm right, arrange a couple of different locations so we won't inconvenience people. And I'm getting nods from both Sally and Stacia. The next president's meeting is May 13th. That is where we will give our gift to Sylvester, and Dr. Stephen Neimer will be with us to speak. So I hope all of you can join us again at that time. I would like to say And I don't think that we can say it enough. Thank you for all of your support. We are successful because of all of you. So in the meantime, stay safe and healthy, and hope I will see you in May. Thank you.